Thanks so much for sharing some time with us to talk about current strategies to optimize clinical, economic, and humanistic outcomes in multiple sclerosis. The program is jointly provided by Partners for Advancing Continuing Education and Impact Education. So we want to thank them for putting the program on. It also is supported by an independent medical education grant from Novartis, so we appreciate that. We've got a couple of great panelists here that will be joining us. I'm so excited to be joined by two very awesome panelists that's going to provide some great insights. And I'm going to just let them introduce themselves real quick. So Dr. Okai.
Hello, everyone. Good morning. I am Annette Okai. I am a fellowship-trained MS specialist. I currently practice in Plano, Texas, and I'm also associate clinical professor at Texas Tech University. And my patients, at any one time, I am managing about 1,200 patients actively and a little bit more passively.
So glad you could join us, Dr. Okai. Jana.
Good morning, everybody. I'm Jana Evans. I am a pharmacist by background. I work now for a health plan, Blue Cross Blue Shield of Texas, and I work in the employer group space, so helping with employers who are self-funded and purchasing pharmacy benefits. So I bring a perspective from really the ultimate payer when we think about treating these different conditions.
Oh, great. Thanks for joining us, Jana. And I'm Dana McCormick. I am currently with Optum Insight on their pharmacy advisory services team. I'm a pharmacist by training and have pretty much spent my whole career in managed care pharmacy, either on the pharmaceutical side or for health plans and PBMs. Thanks, Dr. Okai and Jana. Well, let's dive into some of the nuances and thinking about the different subtypes, how comorbidities impact disease progression, and how you approach a patient, develop policies to ensure that we're taking patient considerations into account. So, Dr. Okai, what are some key considerations in disease management when addressing MS within the different phases of the disease progression? How do you approach that?
All right, so first I'd like to talk about the subtypes of MS. About 80% of patients who are diagnosed with a relapsing form of MS. And relapsing in our space is inflammatory activity occurring, every time they relapse. They get better, they may go back to baseline, or they may have a partial recovery, but there is some recovery over time. And that pattern continues over time. And there are different, we have relapsing, remitting, we have relapsing or active, secondary, progressive, but there is inflammatory activity going on. And then we have the progressive MS, where from the very beginning it's just progression without any significant recovery over time. So depending on that, we tailor our treatment options to the patient. Now, what do we consider when we are making those treatment options? First, we consider how effective the drug is going to be. All right, so we have identified this as someone, we look at the MRI, we look at the patient, and we put prognostic factors together and say, well, what is going to be best for this patient in terms of efficacy? After we look at efficacy, and then we look at the adverse event. Okay, this drug may be great, but for this patient who has fatty liver, is this the best drug for the patient? Is the patient going to take the drug, first of all? We're going to get to the case, but you gave a little taste of it earlier when she had needle phobia. So the best drug we may think may be, an injectable for that, but for that patient, that's going to lead to non-compliance, and they're not going to address the cause. And then as a physician in my exam room, there's always the payer part that comes into perspective. Is it going to be covered by insurance? Are you going to be able to afford the copay? So most of those things are what comes into consideration. So efficacy, adverse events, comorbidities, and then cost. And there are lots of more, but those are the main ones.
All right, Jana, what are some of the reasons patients may switch therapies or discontinue therapies?
A lot of what I consider from the health plan perspective are many of the same things that Dr. Okai talked about. Is it a tolerable treatment? Is it efficacious? But then we also have the aspect of managing cost effectiveness when we think about the payer perspective. So I do think that there are strategies in place that might guide a little bit how a patient perceives that treatment. And whether it's something that's going to be affordable for them. So I think the adverse effect profile and the route of administration have a big bearing on the patient preferences and what they might want out of a disease-modifying treatment, but these are all costly medications, so we know that the coverage will play into their ability to stick with a treatment and finding them a treatment that's efficacious and tolerable and also covered, and getting that pathway to coverage is very important.
Dr. Okai, talk a little bit about how you identify when a patient may need to discontinue therapy or de-escalate therapy. How are some ways that you identify that, and how do you address, and what do you do with a patient in those scenarios?
So the most common reason that we'll think about discontinuation or de-escalating, I'll start with discontinuation first because it's just discontinuation, but now we can de-escalate, is adverse effects. And so going back, once again, I go back to that fatty liver because, that's something common with our diet these days. So if, there is liver abnormalities, almost all except for a few, we have to monitor liver abnormalities. So adverse effects is one reason that will discontinue a therapy. Now we have options. We can switch therapies. Comorbidities, if someone ends up with, I had 5 stents, with my latest, I was in a hospital, doc, and I had 5 stents. Oh my God, I need to consider what treatment I'm putting you on. Then that's a factor. So adverse event and comorbidities. But now we have high efficacy therapies, and those therapies are immune suppressant. We have the good, and I call it good because prior to disease-modifying therapies, MS patients, their life expectancies were 40s and 50s. And since we got disease-modifying therapies, we have patients in their 70s and 80s, and we're like, oh, what do we do about the aging MS population? It's a debate, and it's a great debate because we have people living that long, but then we come back to the aging immune system. Do we need to suppress those people with our therapies when their immune system is already aging, when they need it at this time? So that's where de-escalation come in. So from our high efficacy therapy for someone who is 70 years old, we look at the history. And a big study came out 2 years ago in terms of pulling back from treatment and say, okay, let's see if we can stop treatment or bring them lower. So 70-year-old, their immune system is old. They really don't need to be on an immune suppression, prolonged immune suppression. If they've been stable for 5+ years on treatment, no MRI changes, no clinical relapses, then we say, all right, let's come off therapy, or de-escalate if they're still showing signs that inflammation is going on. We have therapies that aren't as immune suppressive, but they are less suppressive, and they may work at this time in the face of the disease. So all of that comes into play when we are thinking about therapies in patients, and do we stop, do we discontinue, do we de-escalate?
So digging in just a little bit more, so you've mentioned a little bit about liver concerns and cardiovascular concerns, aging, the way it changes as people age. Talk a little bit more about how you think about other comorbid conditions that a patient may be experiencing and how that influences your treatment decisions. And then can you also talk about how it may impact the prognosis and the disease progression for a patient?
All right, so let's talk
It's a big question. It's a lot there.
So first, we'll talk about the common American diet and the current American. So hypertension, cardiovascular disease, fatty liver, diabetes. So those things, if uncontrolled, impact MS symptoms. Those also promote inflammation. So we have to make sure that those are controlled. The blood pressure is controlled, diabetes, blood sugar is controlled. Otherwise, patients feel unwell overall. They feel, oh, I just don't feel good, but that's because other things aren't managed to make them feel better from the MS perspective. And then, as I said earlier, it also impacts how we treat the patient. You know, if they have a drug that we have to monitor EKGs or heart rhythm abnormalities, and most of our drug liver abnormalities, then that comes into play. Another big thing is mental. We're talking about depression and anxiety. So while MS doesn't cause depression, MS itself leads to depression. And with depression and anxiety, you also have symptoms that the patient, fatigue, lack of motivation and all of that, which directly impacts MS and how they deal with the MS. So dealing with that as well, making sure that depression is treated, anxiety is treated. One or two of our medications do affect the mood, and we have to say, well, this may not be the right medication for you. Let's look at something else when it comes to that. And so when we put all of that together, we make the decision to say, but this is what is best in terms of treatment options. This is what you need to work on. As a physician, I tell patients it's a 50-50 partnership. You come to me and I try to put together the best treatment option, a plan for you. Your part is the lifestyle. You have to work on your weight. You have to work on the blood pressure, diabetes, cholesterol, whichever is impacting you. And eat healthy, because without that, I'm going to just be treating and you're still not going to feel well. And then other autoimmune conditions we have to take into account. Thyroid is a common comorbid disease with MS. We have to make sure that the medication is not affecting the thyroid. And then if the medication does affect thyroid, we're monitoring for it. So all of those things come into play.
So there's a lot of complexity about this disease state, not only thinking about all of the different subtypes, thinking about all of the impacts that other comorbid conditions that patients have may affect the different needs for therapies to be chosen. And it's complicated. How would be some ways that we could help ensure that patients are getting access to the treatments that are going to be most impactful and helpful for them to delay disease progression and maintain function?
I want to say, oh, let's provide more nuance into our criteria, and that's kind of an antithetical statement. But I do think there needs to be some consideration for the complexities. So when we think from a payer perspective and from the managed care perspective, a lot of times we're thinking about a population as a whole. So how do we get the optimal therapy in general for the most amount of people? But we have a disease state that's much more complicated than that. So obviously, prior authorization and criteria is a big part of how we manage this, and considering things like disease activity, where someone is at in the progression of the disease, I think could be very helpful to help determine which is the best drug at this time based on the findings. So building that into the thought process when we think about coverage criteria would be very important. Assessing history, obviously, what has worked and what hasn't. And then the comorbidities piece brings in a lot more nuance to that criteria. But as you were speaking through that, I thought, wow, that's a great role for a pharmacist. What a better case for medication therapy management for some of the interventions that pharmacists can help with to optimize the treatment selection, but also address the comorbidities as well. I think there's a lot that can be done from a managed care perspective, thinking beyond some of the traditional mechanisms like prior authorization, and even within prior authorization to make it a little easier and more flexible to take into account these patient individual needs.
Dr. Okai, how difficult is it for you to, again, working within the framework of prior authorizations for, the 75 different plans that you probably have patients that, have that are coming to see you, out of your 1,200 patients that you're, managing? I can only imagine how many different plan types there are.
Yes.
How is it for you managing, again, thinking about all the different subtypes, all the things that go into treatment decisions? How easy or difficult is it for you to work within the framework of prior authorization that plans have set up?
Very difficult. Very difficult and frustrating. Frustrating for my office, frustrating for my staff. And I will say sometimes resentful, and I'm just being open because I feel like I can't practice the way I want. I have to practice within this when I'm dealing with a disease that we call the snowflake disease, where everyone is different. But you just said something, I'm like, while I thought about it in that way, it just didn't click when you said you think about it as a population base. So that just clicked for me. Okay, I see something from their side now. But it is because everyone that comes into the office is so different. Yes, we put them in subtypes, we put them in groups. But within that group, then you have so many different things that come into play that within that group, I can't just use one. There's no algorithm for MS in the exam room. The payers have algorithms, and that leads to the frustration, but it's hard to go with the algorithm when I know if I do this, I'm actually opening that patient up to more disease activity before I can get to what I want.
Yeah.
Yeah.
So we talked a little bit earlier about the potential role that biomarkers could play in helping, again, create, because one of the big things that's problematic is you're developing a population-based approach. How do you efficiently build in a way to identify, patient preference and comorbid conditions and things that impact? How could biomarkers play a role, and what do you see the future of that being?
I'm so looking forward to biomarkers. Our biggest biomarker and most effective one is an MRI right now, but that's just a snapshot. It's a snapshot, but it gives us a whole lot of information, but there's limitation in prognosticating. That is the issue with biomarkers. CSF fluid, is not very conducive doing CSF all the time on patients. What I started to use recently, approved by the FDA in 2022, is the MS disease activity test, where it's just a blood test. In addition to MRIs, I can say, okay, there's high, moderate, or low risk of MS disease activity. Obviously, when someone comes with a relapse, I know it's going to be high, but if they're on a medication and they're still in that high group, then something's telling me I'm not controlling inflammation. that's the time I'm like, okay, we are going to the bat, we're going to fight insurance. And and I say fight because, but we're going to go through all the processes, the 2 denials, the appeal, and then the peer-to-peer before to get this patient what they need, because everything is telling me here that this is not a good prognostic factor for this patient. So looking forward to lots of other, there is the neurofilament light chain, which is so far one that has progressed past initial testing that we're also using a lot. So looking forward to it where I can just do a blood test and couple that with MRI and say, look, this is what I have and this is what I see, and we can put that together and say, this is the best one for the patient. And then personalize treatment options for the patient, because for a disease that is so heterogeneous, I think personalized treatment is important.
Sure. I think too, one of the difficulties that payers have when developing policies, right, is the definition of what mild, moderate, and severe is. And a lot of times we end up with drugs that will have an indication that states for mild to moderate, for moderate to severe. And so sometimes not having that clearly defined makes it more difficult for a plan to develop those coverage policies.
I would say so. And as you were going through the different biomarkers, I was thinking that that gives a lot of promise to be able to better define severity and say, for this patient, we have this evidence that we think the disease is going to progress in such a way that we might need to use a therapy. And it helps to bring the justification for some of the higher cost treatments, knowing that it's very important to get that efficacy early on. But I think that can bring a lot of harmonization between the personalization needed and the more algorithmic nature of the criteria.
So we've talked a lot about the disease process and therapies, but I always think it's very important to put all of this information in the context of a patient. And so Dr. Okai mentioned earlier that patients should be the center, and improving outcomes should always be the center of everything that we're doing. So let's actually take a case and talk through that. So we're going to talk about a patient today who is a 38-year-old African-American female. She's married with 2 school-age children at home. She works full-time as a pharmacy technician. She has Graves' disease, and she's had that for 5 years, and she currently is taking levothyroxine 125 micrograms per day. Currently, as she comes in to talk to her physician, she's talking about numbness and tingling in the lower extremities, and that's been going on for about 6 months. And this has led to her having poor balance. She's had new onset of vision changes, so is experiencing some blurriness, feeling tired, and she describes the tiredness as feeling like she has not had enough sleep. Her current exam results show reduced strength and sensation in bilateral lower extremities. She has impaired coordination, and she has an EDSS score of 4.5. Dr. Okai, can you just tell us EDSS, just a high-level overview?
EDSS, Expanded Disability Status Score, has been used in MS for a long time, and it just assigns points to the neurological exam, and we come up with a number for the patient. And so it's a scale going from 0 to 10, with 10 being death. What is challenging, or the limitation of the EDSS, is that it's highly weighted to motor activity. So gait and walking is what is the highest score. It doesn't take into account cognitive, bladder, bowel, even though it's on there, but very, it's not weighted as well. So it's what we have now, is our standard, and it's best that we have, but it's very limited because it only gives you, not only gives you, but is strongly weighted on mobility factors.
All right, so this patient also, she has already been diagnosed with active MS. Her neurologist would like to initiate treatment with a high efficacy disease-modifying therapy. Her payer coverage policy allows for or follows kind of an escalation strategy where the patient must first try platform therapies prior to a high efficacy therapy. So Dr. Okai, what factors around this patient should be considered? Again, we know the coverage policy is a more escalation approach, but what specific about this patient makes them a good candidate for access to high efficacy therapy?
Give me 30 minutes.
Yeah. I can already think of like 72 just based on your previous comments.
So first, she has gait and balance issues. So that's when people think about MS, they think about wheelchairs, they think about canes and mobility issue. So this is something that is visible to everyone. Her EDSS is 4.5, meaning she is probably she's one step away from using a cane or walker. And I mentioned earlier that we need to treat effectively early on to reduce that disability. If we can keep patients below, because once they pick that up, it's so hard to slow that progression. There have been studies that once someone passes 4, their trajectory is faster to a cane or a walker than keeping them below 4. So that is the first thing. The EDSS is a big sign. The symptoms, let's talk about the symptoms she's presenting with. Balance, walking, vision. She's a full-time employee, all right? She works as a pharmacy technician, so she needs to think constructively. So she needs to think logically. What people don't, not what people, but the outside world do not see is that MS have a whole lot of invincible symptoms that causes disability, cognition being one of them. Fatigue is over 50% of people that leave the workforce is due to fatigue when it comes to MS. Cognition is, I think the number is even higher, and people see them walking and talking and think that they are competent, but they are not competent. So her age, she's African American. There has been studies showing that certain platform therapies do not work as well in the African American population versus the non-African American population. So all of these things can only, based on her symptoms, her MRI will show lots of lesions. So she already has, loss of CNS tissue, and we need to preserve what we have by reducing the relapses, by trying to keep her stable and not let her go down that slope of disability. Lots more.
So lots of reasons why this would be a good candidate for high efficacy therapy. Dana, talk a little bit about just overall strategies of how payers currently are managing MS.
So I think in this case, we mentioned kind of the platform approach because that's how we think about cost effectiveness of medication. So we mentioned prior authorization as one of the mainstays of managing MS therapies. And we're always thinking about ways that we can use something less costly if it's efficacious. This is developed into somewhat of a generics first approach in a step therapy kind of thought process to say, well, is there a less costly treatment we can try? Maybe that's not as highly active though, so that's a trade-off in terms of the long-term costs when you think about managing a patient. So really, those kinds of step therapies are common when we think about the utilization management of these types of therapies. Other things that are used depending on the treatment, we'll look at navigating to a certain specialty pharmacy, or for infused medications, how can we get it in the most optimal site of care? which can be easier for the patient too, especially if something's able to be administered at home, for instance. But it might not be the reality based on the safety profile for every type of high efficacy DMT. There's a lot to balance in there.
Yeah, so just what you just said, so the way I think about it, you said a generics first approach, but the generics are, after the patent runs out, then the generics come to the market, and we know that. So that will mean, the medication first, whereas in the clinic, I'm thinking we're withholding the effective ones to go back to treating in the 90s when we're in the 21st century, and we have data showing this, even with the short amount of time that they've been on the market, has changed the course of patient disease overall. So that's where the disconnect comes from. When I see the escalation approach, I'm like, this is what we're doing 1993 to 2004, and now we're 20 years later, and I'm still being asked. I wasn't even practicing in 1993. But that's what we're going back in terms of treatment, when we should be moving forward with, let's get this under control, and then we can de-escalate. And for me, in my mind as a physician, I'm like, that saves a whole lot over time, because you're saving treatment for, you're not treating relapses in patients entering the hospital, going to rehab after hospital, and all the treatments. So that cost, I think, and correct me if I'm wrong, I don't think the external cost is factored into that when you talk about utilization. I'm just speculating. So I think, this medication costs this much, and generics are this, so we'll go with this. But then, hospital costs, rehab costs, this cost all falls into that. So the indirect cost of treatment is something that needs to be taken into consideration as well.
As we think about those pathways, that's an important factor to consider beyond just the cost of the drug therapy, because you're right that those are potentially even more costs than the drug therapy when you think about an escalation approach. So there's an opportunity there to think about more than just the cost of the drug therapy when thinking about designing the criteria and what will be most effective in treatment.
I do think too, it is like, going back historically with the first therapies, and I think a lot of times there is this delay that occurs. There's a delay in clinical inertia, for example, so new therapies, and when new guidelines come out, there's that delay in getting acceptance and for that to become the standard practice. Likewise, I feel like sometimes there's a delay when you have, products, and then you have like a really, and again, I'm going to say quick influx. I know this has happened over several years, but quick influx of new, very efficacious, better products than older products. I do often see this delay, and I can think about several disease states where, it took a while before the like the standard of care. Like I think about diabetes as a good example, where, now therapies that have been around for a while that we knew were very effective are being used earlier in treatment because they are more efficacious, and that the idea of treating earlier, but to the point about understanding the disease process and things like how, immunogenicity, decreases with age. So it's important to treat the neuroinflammation early on when you can. So I think all of those things coming together will help inform and create access points to earlier access to those disease processes. But it's, just takes a little bit of time. But think about, like, are there ways, how could plans potentially create or think about ways of incorporating disease progression or adherence concerns around, therapies? Like, are there ways that they could consider that building into policies to help?
Yes, so being able to define where a patient's at in that progression could help make a case for using a highly efficacious therapy, or thinking about how many treatments they've tried so far. So we might think a little bit differently about a patient who's trying their first disease modifying therapy, and that could be a pathway to say, we need a highly efficacious treatment here. And we still have a whole handful of options that we've had for at different cost points, right? Down the line as we think about the disease process. So bringing in, again, those prognostic factors could make that pathway, and defining where the patient's at in their treatment process can help to bring the best DMT, the most optimal one early on, and remove some of those coverage concerns.
So I think one of the things that, again, in the context of specific patient care and thinking about a patient, I think this is always a great time where we can kind of bring up this idea, or not idea, but just talk about what are the things that we can be doing to help remove disparities, and how do you think about your patients and recognizing that there is, health equity issues and concerns? Like, how do you think about that in your practice, and where do you see it in your practice?
So I have a heterogeneous practice too, and so I have a mixture. People come. I'm a tertiary referral center, even though I'm now in private practice. I was in academic before, because specialists are needed. And so I have urban, suburban, rural. I have Caucasian, Black, Hispanic. So I'm in this crossroad. I practice in Texas, and I have this crossroad patient. So I have a unique opportunity to see a lot of things that impact, barriers to care, or health equity and equality and all of that. So first, let's think about the African American patient that you just presented here. So what has been MS historically has been a white disease. And now, over the past 5 years, has shown that Black women are the #1 group that are being diagnosed with MS. Over the past years, MS, a white disease now, the African American population have more rapid progression of disease. So they go to cane, wheelchair earlier, they end up in nursing home earlier. The disease process, we're still trying to understand why it's different, but we have seen the phenotype that have changed over time. So when I see demographics do have to come to my mind when I see people that way. Then I have the rural versus the urban, the access to services. When someone drives 5 hours to see me, and I'm like, well, you need this type of rehab, you need urogynecology, and you need this, and they don't have it in their area. And I'm stuck as to what to do, because we know it's not only about the disease-modifying therapy. Rehab services are better for patients, especially if they have mobility issues. Then I have the insured and the underinsured as well, or the no insurance who's paying money to come and see me because they need help. Then I have to figure out in my head, okay, where can I get them therapy that they're going to get copay assistance, that the pharmacy is not going to say, we're not going to accept that copay card for you, you need to pay this. So all of that comes, with MS, and there are so many more than you have. Yes, it's just so much that you have to think demographics, social determinants of health. Are they going to be able to get to their treatment if I prescribe an infusion treatment, which I consider high efficacy therapy? What is the logistics for them in getting that?
It's a lot.
Yes.
What role do payers have in helping address SDOH and helping decrease disparities?
many of these things can be addressed from a payer perspective, things that you're talking about, helping with coordination of care. So helping figure out where the doctors are that someone can go to for some of these supporting pieces. Addressing transportation needs for patients can be accomplished from a payer perspective. So it's thinking more about care management models and how do we address those social determinants of health within it. And then when we think about plan design, that can be used to address affordability. We cannot single out a particular disease state when we think about plan design, but more broadly, most of the disease-modifying therapies fall within the specialty realm. So there's an opportunity there to look at specialty pharmacy in general and the cost burden that we're putting on a patient to address the affordability of MS care and to make it accessible to the patient. Or maybe there's not a need to put such a large cost barrier on these different treatments. Particularly, there's been a lot of interest in high deductible health plans. So that's a place where we can think about for specialty therapies, for conditions like MS, where time is of the essence, can we remove the cost barrier of a deductible in general to make that easier for a patient to get to? And some of those conversations are starting to happen, but we are also in a very cost-sensitive time. Yes. So again, understanding the full indirect costs that come from not getting the right disease-modifying therapy versus maybe the short-term increase in plan costs as you look at the cost share structure, that can be used to better support the affordability case.
All right, Dr. Okai, tell us just real briefly about what you're excited about for the future.
I'm excited about tackling inflammation in the central nervous system. That's an unexplored world, and I think it will change the face of the disease as well in terms of how patients' disease is managed and the outcomes of their disease. So inflammation in and out of the central nervous system is what I am excited about. And I look forward to what molecules are out there outside of what we discussed to reduce that part, the late part of MS that we haven't really gotten a grasp on right now.
All right, what's your one takeaway that you'd like the audience to take from this?
So my one takeaway, since I'm speaking to a group of payers, and I said it earlier, MS is a heterogeneous disease. It's a snowflake disease, we like to think about it. And we need to move towards precision medicine, probably not personalized, but precision medicine, and not just follow an algorithm overall. And I think continued dialogue between payers and for us in the clinic, because sitting here, I've gotten insights that I didn't have before, even though it was there somewhere, the pieces didn't click. So I think we need to continue the dialogue to optimize it for the patients.
All right, Jana, what's your one big takeaway you want everybody to leave with?
I would agree that I would like to continue this type of dialogue and get a bit better understanding. And you really had me thinking about ways that we can ease the prior authorization process. So that's what I'll be leaving with on how can we make this work for the individual a little better.
All right. We have some questions. So Dr. Okai, can you point to the literature guiding de-escalation strategies?
So they're published about 2 years ago, 2022, was the DISCO MS trial. The lead author on that was John Corboy. I'm sorry, the author is John Foley, not Corboy.
John
Sorry.
Foley.
Yeah.
Okay, awesome.
But it's the DISCO MS trial looking at discontinuing treatment in the older population. That's the one we are referring to a whole lot at this time. And that's the main one. There are a few other regarding escalation versus high efficacy, but the main one is the DISCO MS regarding discontinuing medication.
Dr. Okai, is therapy always lifelong, or are there instances of stable disease where there is not evidence of inflammation when a patient would just discontinue MS therapy?
So there is evidence of stable disease when treated. All right, so the natural history is that patients will have some over 85% of patients will have progression even though you're not seeing regular inflammatory activity. But treated, we have patients going 7+ years, 9+ years with no evidence of MRI activity, no evidence of clinical progression, and we call that NEDA, no evidence of disease activity, which we look for overall. But it's for treated patients. And that's where biomarkers come in, because it's so difficult to tell that who's in that 15% that's not going to progress over time. And as the patient ages, this is a new population for us, the aging population, and where there are lots of studies ongoing right now. So DISCO MS was the first one to be published, but there is still TREAT MS ongoing, and the preliminary data from that is very encouraging for early high efficacy therapy versus escalation. There is DISCO TREAT. I'll get to the other one. But yeah, there's evidence that we can keep patients stable on disease-modifying therapy, not leaving them to their own devices. It is a lifelong disease, but it can be stable.
Jana, from a payer perspective, have you ever considered a patient's productivity as a reason to cover medications, considering the idea that patients get their meds earlier, their disease is treated earlier, better outcomes, and avoidance of disability?
Certainly, working in the employer group space, this is a conversation that I have very frequently. There isn't always the defined literature on what that really means. We can talk anecdotally about that, and that typically resonates in the commercial space quite a bit, to make sure that someone can continue to work with the disease because they don't have disability. There's a lot of room to better define those outcomes when we're looking at the different treatments and that could also help with starting high efficacy DMTs, having more of that defined outcome humanistically in terms of work productivity.
I think that is one of the things, I think Dr. Okai, you mentioned earlier about taking into consideration the cost to society. Mm-hmm. So I do think that's one thing that, again, it's hard to actually, again, we know there's a cost for disability for patients, yes. Not just their quality of life, but there is a cost associated to that. So I think that's one of the things that we need to continue to evolve into. Yeah. So recognizing there almost always is a delay to diagnosis, because it's a complex disease. It presents in ways that may lead to ruling a lot of things out before you come to a diagnosis of MS. Is there anything you're aware of that's coming that can help with earlier diagnosis?
So outside of the MRIs, it's all, advanced MRI imaging. Okay. We don't have a blood biomarker at this time, and CSF is not feasible over. So it's the advanced MRI imaging that will help. But overall, sometimes it's education of the physician. So sometimes it takes a longer time for the primary care to make a referral. And sometimes general neurologists or other neurologists may look at other things first. The education has to start with the physician to recognize the signs and refer, and not say, well, this is all anxiety or depression. Studies have shown that patients have been sent away from the ER, they're weak in the leg and they're like, you're anxious, or something to that effect. Not all doctors are bad, by the way. These are just extreme examples. But educating the physician. But I think for now, our MRIs, our standard MRIs and advanced MRI markers are what's driving the diagnosis. And instead of just looking at the lumbar spine, make sure we go up and look at other things.
No. So last question is, would a CIS subtype be treated indefinitely?
Yeah, so once we start a CIS and you meet the other criteria, even though it's CIS, yes, we treat you, especially if you are young. Now, if you get to, 55, 60 and things are stable, then we may consider taking you off treatment. But there is no data right now that once CIS start, we stop after 5 years or after 10 years or anything to that effect.
Jana and Dr. Okai, thank you so much for joining us. I really appreciate your insights. Any closing comments from either of you?
Well, it's been a pleasure sitting here and meeting with you guys and learning more. Jana, thank you for your insight. Dana, I appreciate the moderation, and I hope this could continue. I really enjoyed the interaction.
Awesome. Thanks for joining us. I hope you got a lot out of the session. So again, for those that are going to be wanting to receive credit, you do need to fill out the evaluation. I want to thank PACE and Impact Education again for putting the program on. Thanks to Novartis for providing the educational grant. And I hope everybody has a great rest of the day.